There we are. See if we can get it to go here. There we go. Always good to have something go wrong when you just barely start off. I'll resume slideshow. Is that what I need? There we go. All right, my apologies. So that's me. So here's the learning objectives for what we're going to talk about. It's basically the public health and mental health collaboration, how they intersect between public health and mental health. There's a lot of intersection between the two, to say the least. So here's some of our training objectives. You'll understand the structure of the mental health support system. And I do that with a case of MEL. That'll be, and I'll explain why I use that one case as we go along. Why are they public health issues? I think very much they're public health issues. They're entwined with everything. And how can we have them both? Addressing community mental health, etc. And I look for common etiologies too, common exposures between physical illness and psychiatric illness. And then finally, the key terminology that we'll talk about that is a lot of things are pretty unique to mental illness, but really there's quite a few things that overlap. It really overlaps a lot. When I was creating this talk, it was not so much of a matter of will I have enough material, but how can I narrow it down to 2 hours? This was my main challenge. So I like using this. I like starting off with my public health, the core functions. I teach public health now at Helena College. We're trying to actually develop a public health collaboration with the University of Montana. So as I go through this talk, I'll be looking at these, particular monitoring health, information in particular. I have a lot of that, but all of them, frankly, all of these things I think are good to keep in mind. For me, it's helpful to keep these in mind as I'm thinking about public health in general. It helps me categorize things, right? Where I say, okay, we're falling under this assessment, falling on that one, et cetera. So I think that really, it helps me, and I'm going to keep that in mind as we go through the talk. And please feel free to put things in the chat. Desiree will interrupt me, and I think I appreciate that. So don't worry about that. And my teaching style, I guess, before I go going too far, is I really like to have the interaction. So if you do have any interactions, please just, again, just sort of let me know. So the story of Mel. I'm going to start off for the culture, the story of Mel. In my abnormal psych class, I have a whole mental health system, kind of just a fiction one. And I have patients come in and the students have to figure out what's going on. So one of my main patients, if you will, is Mel. He's Mel. He's 22 years old, a 3-year history of schizophrenia. And I'm going to add in that as a teenager, with his family history, he has a family history of schizophrenia. I'm just going to say his uncle had schizophrenia. And Mel, when he was a teenager.
Quick thought. I'm kind of leaning towards holding off on.
Whoop, somebody's being there. Sorry about that. Auditory hallucinations, perhaps. So when he was a teenager, he smoked a lot of pot, THC. And as you might know, you probably have heard of this now, especially if you have a family history of schizophrenia or other psychotic illness, and you use a lot of THC, the high potency THC that we have that are out now with the legal THC, it increases your risk of having schizophrenia from approximately 1% baseline up to 30 in a dose-dependent fashion. So just to start off, we don't need to think about that, right? That this is contributing to the mental health burden and subsequently the overall healthcare burden with THC and schizophrenia. Moving along, erase all the ink there. So he currently is on Medicaid. So that's the federal government. Got on Medicaid, which is not necessarily easy to do either. I used to work with some lawyers that would have people get on Medicaid and Social Security. So it was quite difficult, although with schizophrenia usually was not too much of a problem. Next up in the system is a mental health center. He has a mental health center that provides psychiatric care, psychotherapy, etc., including a group home. This issue, understaffed and inadequately trained, is one that I'm going to focus on various places throughout this talk, especially the support system, because I think it's a major area that we need to improve upon. And that's the assure competent workforce. All the ones in blue is how I fit it into the essential tasks of public health. He's on medication, Ziprasidone, Viatris, and that brings up the pharmaceutical companies. That's part of this overall system, is the pharmaceutical companies. So are they out to make money? Of course they are. They're a company. And they also, one of the main reasons we have these various medications are through the companies. So I think that's very much part of this overall system when we're thinking about how this should go. And of course, there's psychiatrists and APRNs, advanced practice nurse, registered nurses, do a lot of activity now when it comes to taking care of patients. There's about as many APRNs as there are psychiatrists at these some of the international conferences I go to on psychopharm. Advocacy organizations, okay, they do support right to refuse medication in general. That's a bit of an overstatement. I'll say that mainly, a little bit of artistic license here, right, to kind of as proof points. But people do refuse medications. That is part of our legal issue. So what happens? He relapses, of course, and that's psychosis will relapse. He walks away from the group home, and ends up sheltering under a bridge. We're now talking about the homeless problem, the homeless problem in the overall system, which is, as we all know, huge. After he calls, he was smoking cigarettes, he was yelling at people. Community members are a big part of this overall system, of course, because they get to interact with folks. They have to understand. I think if people understand mental illness more, it becomes far less frightening, right? Far less weird, if you will. And of course, family, Mel's family, that's very important. Then we start getting into some of the legal, right? The police will pick him up. Even though the mental health issues, police are usually the first ones on the scene. Next up in the support system, Mel is brought to the emergency department of a local hospital. So emergency departments see all kinds of mental illness or suicide, which we'll talk about after a while during this presentation. So local hospitals are definitely part of the support system. As the ACT, Assertive Community Treatment Team from part of the Mental Health Center. We're going to get rid of some of the things there, too cluttered. They see him, and his psychosis is legally an acute threat to others. Okay, so we have to have the acute, right? That's a big point. They have to have an acute threat to self and others, not sort of chronic, but acute. Local hospital, the psychiatric unit might be full. Again, a little bit of creative license on that. So it's full. So the judge, here's a big issue that people, I think, don't consider when they're looking at the mental health system, is how much judges have to play a role in it. And of course, now they get to Montana State Hospital. I have a sole slide where we talk about that as the overall system. It actually has a lot of medical issues that go to the state hospital. I'm kind of a full disclosure, my wife is a psychiatrist at the state hospital, so she has an idea of what it looks like down there. And then who brings them? The sheriff. The sheriffs bring them to the state hospital. So depending on where they are in Montana, they may have 2, 3, 5, 6, 7 hours in the sheriff's car going from wherever they are to the state hospital. That's a long time. And here, of course, we're mobilizing community partnerships. So you can see how all these things come together in the overall system from this, the story of Mel. So, and I'm going to this, picking up a lot. You can't smoke at the state hospital, right? You can't smoke at the state hospital. That's just the law, which makes sense to a degree. So we'll get into that too. Prescribes clozapine. Clozapine is like, it's one of the few drugs in psychiatry that's better than the other drugs. Its ability to treat psychoses is frankly better than some of the other ones. It's and we don't know why. It just sort of by happenstance it is better. It though it's better, but also a little bit more of a hassle. You need to have lab tests. So now we have phlebotomists in part of the care. So you have people who are psychotic, manic, whatever they might be, intoxicated, needing to go to a lab to get blood draw. And he improves. Well, improves, of course, gets ready for discharge. But unfortunately, the group home's closed, staff shortages. The judge, though, given that he no longer is a threat to self or others, has to release him. He no longer meets criteria for involuntary care. That's the laws, right? And this is, when in Hill and I work a lot with folks between kind of coordinating between the state hospital and community providers just to add education. Some folks didn't realize that you have to be involuntary committed to the state hospital. They don't take voluntary patients. And if they are brought to the state hospital, they have to take them. So state hospital has no recourse, but he walks away from the courtroom. This happens. We don't know how much this happens. I think this is a concern of mine when we look at the overall system. How many times will this walk away? I know a friend of mine would complain that the state hospital discharged somebody to the street. Well, did they, or did the judge, frankly? And if they don't meet criteria, that's what happens. And he ends up they did get him into a homeless shelter. Again, homeless shelters are very much part of the system. So at the mental health center's medication, he was booked out for months. Right? They're chronically out for months. Medicaid hasn't restarted yet, so he's out in the community because he just walked out, right? Just walked away from the courtroom, doesn't have Medicaid. So he got to look up with a primary care provider at a public health center. Part of the large system, they certainly have this. Predictably, he starts smoking again, right? This is an issue I don't think we address too well because smoking increases liver metabolism. So even though he had a nice level, we'll say, of clozapine and it was treating his psychoses, he's now smoking and his clozapine levels, they essentially plummet. They go down really fast. And his clozapine levels drop. He gets back into psychoses and repeat the above slides. Does that sound familiar? And how this goes? Kind of the revolving door, it's called. One hinge, if you will, of that revolving door might be this issue of cigarette smoking at the state hospital. I think it's a very interesting issue. And by the way, you may have heard of pharmacogenetics, where people want to test how fast you metabolize a drug. Are you a fast metabolizer? Are you a slow metabolizer? That is sold, frankly. That's sold as being a way to know which medication works for you. It doesn't do that. I feel like pointing that out to people. It does not do that. It shows what the liver does, not what the brain does. And it changes. This example here is a common one where going from not smoking to smoking changes your liver metabolism, makes you from a slow metabolizer to a fast metabolizer. So pharmacogenetics doesn't have really that good of application. It's been around for a long time, but I think it's been around for a long time because it seems like it should work. It's one of those things that seems like it should work, but it doesn't. As I like to quip, livers ain't brains. How am I doing on time here? I'm doing good. Erase that. Again, if you have questions on any of this, please let me know. So, back to the state hospital, revolving door thing. Now, instead of clozapine, because of this issue of smoking, we'll just say, gives us long-acting injectable, LAIs. LAIs are really good. We'll talk about it when we get down the page a little bit. So his psychosis improves again. Chaplains, the faith community. The chaplain at Montana State Hospital is like an amazing person, but they really help reconcile psychosis and spirituality. This guy's amazing at doing that he has, delusions around Satan and things of that sort. And the chaplain down there is able to kind of tie those together and help patients. But the faith community is very much integral into the overall system, including social chaplains at the state hospital. Julian's coming in. So at the state hospital, they have social workers. Okay, the social workers. We have University of Montana has a 2x2 Bachelor of Social Work program. Again, looking at the education now, getting into that part of the system, where the first 2 years are at a 2-year school, Helena College, for example, and a bunch of other ones. But then they go for the last 2 years online with the University of Montana, and that's really good because we need social workers. Again, adult foster care, a little bit different than group home. So that's why I have that differently placed in here. And then he returns to the mental health center, which is good. Which is good. And he now has a psychotherapist. Sometimes, and again, I'm kind of keeping this very general in my mind as to how much I put into here. So sometimes we don't think of schizophrenia as someone with schizophrenia as requiring psychotherapy. They really do. There's a lot of good evidence, a lot of good data with psychotherapy and schizophrenia, even cognitive therapy, learning how to cope with hallucinations, which is very interesting to me, to do that, but also just education around the disease. Case managers are so crucial. If you have a good case manager in your overall system of care, I mean, think about all the things he's involved in, right? He has Medicaid, he has social work, he has the adult foster care, he has psychotherapists, etc. So there's a lot involved. The case managers is crucial for that. Then, once a month, bi-monthly this time, it can be we got somebody in the chat. I don't know if anybody has a question there. I see it popping up. And so I'm going to ask go a little bit on the long-acting injectables. So do we have a chat question? I just see a chat popping in.
I don't see anything on my end. So.
Okay. So, and then one of my public mental health projects, if you will, is to have long-acting injectables very early on. So they have a lot of advantages. One, you don't have to be reminded once a day that you have schizophrenia. You have to take these pills. They shouldn't be thought of as punitive, that you haven't taken your medications, therefore we're going to give you the shot. No, that's not the way to think about them at all. They give a steady state of medication. They preserve, and you don't have to think about getting a shot every month or two, sometimes three. So that's better. You're sure to get it. And it actually preserves brains, like seriously preserves brains. Every time you have a psychotic episode, you lose brain tissue. And it's a degenerative disease. It just seriously is. And if you have too many psychotic episodes, you're going to be more and more refractory to care. So those need to be used extremely early on. And of course, NAMI, National Alliance for Mental Illness. They have the Family Program. They're another advocacy group. Advocacy groups are huge as far as overall support system, mental health support system structure. They do a lot of amazing stuff across the state here in Montana, and of course, the National Alliance for Mental Illness. If you do have a question and you're in the chat and doesn't sort of hook up, please just chime in. That might be an easier way to do this. So now he's in recovery movement. Okay, the recovery movement is really quite essential. It's the idea that you don't just have this psychiatric illness, that you're a person. Okay, the recovery movement is really quite big, and I think among the most important things of our system. It's really, I think, it's just frankly beautiful, if I may be so emotional around it, and became a certified peer support specialist. We have Montana Peer Network here. We have quite a few different peer systems. There's particular training for peers and the data. If you get to know me, you'll know that I'm very much into science, that I have to see what actually is out there in order to say, yeah, this works or not. The whole idea is it seems like it should work, doesn't work for me. That doesn't work for me. So state legislatures, of course, they're the ones that are making the policy and the laws around mental illness. And I'm using this example as an example. Yeah, and it's not a bad idea allowing smoking at the state hospital. It's pretty, I don't know, people probably don't like that idea because it's just a bit out there. But when you think about it, one, they're going to smoke when they get out. They're going to smoke when they get out of the hospital. It's not like in the time at the state hospital, we're going to prevent cancer and heart disease and everything else because it's a very limited time. And when they start smoking again, the treatment they're on, especially if it's clozapine or olanzapine, those go away. They get more psychotic illness. They get less brain, right? So we're not preventing heart disease and cancer, but we are making psychiatric illnesses worse. We're having brains die. So I don't know. I toss that idea out there because I think it's something that really might be worth considering. And from doing that, now back to family, the Drug Utilization Review Board, they might want to help them use LAIs earlier, long-acting injectables earlier. From what I understand, and I have to look into this a bit more, quite frankly, that you have to, quote unquote, fail a few different LAIs before you can get on one. You can say, so you get psychotic or you're not adhere to treatment. I think that's just wrong, and I'm really sure. No, I'm not really sure. I'm absolutely positive that the literature supports this. And so the developing policies around having these LAIs earlier I think is just crucial. Yeah. So what all do we see? Well, quite a few federal things, right? The CMS, Center for Medicaid and Medicare, Medicaid itself, getting on Medicaid takes a while because you lose Medicaid when you're at the hospital. I don't know if that makes sense or not. I guess I understand it, but it sure seems like there should be a system to get back on Medicaid pretty rapidly. And again, if you're discharged straight out from the courts, yeah, it's going to be hard to keep up with that. That's for sure. Pharmaceutical companies. I mean, there are some medications coming out for both depression, anxiety, and schizophrenia in this case that are really quite unique. They're quite unique, and so that's good. Pharmaceutical companies have motivation to have good medications, right? Because if they don't, they lose money, right? They'll go broke. And then advocacy programs; those are nationwide too. On the state system, the state hospital, legislatures, Drug Utilization Review Board, DPHHS involved in all of them, and advocacy groups at the state level as well. Down to the county, sheriffs, judges, hospitals, inpatient psychiatry, homeless shelters, mental health centers, and federal, all these different things come together to take care of Mel. I want to take care of one of my favorite patients, Mel. And then a lot of local things, public health members, community members, everybody's involved in this, having an understanding of what brains do, how brains work, and what these disorders are. I think, well, I like giving illustrative anecdotes, and one illustrative anecdote is is there a question?
She's like, it says,
Nope, that's someone who's not muted. So, I need to unmute myself. Sorry about that. So, living with Zoom, all kinds of fun. And I think some of these things, public health centers, lab services, again, do we think about laboratories, phlebotomists as being part of the mental health center? Generally not, but they certainly are. They certainly are. And how many treatment providers we have? A lot. Peer support, group home staff, phlebotomists, psychotherapists, APRNs. So to take care of one person with schizophrenia, it takes a lot of people. It takes a lot of people to take care of that one person. So I think I'm giving a pretty good view what it takes to take care of somebody with mental illness. So I had some of these here. These none are afterthought. I just had a couple more bullet points that I wanted to elaborate upon. So native system, okay, we have the tribal processes, of course, Indian Health Service, and the relationship between the tribal sovereign nations, county, and the state hospital can get fairly complex working between the two. You have to have the cultural appropriateness between them. They have their own legal system, of course. So all of those are part of the system. And is there anything other than those different separate systems that you have to maneuver? Not really. I mean, the issues with valuing family and all the other ones that are very beneficial from the native side of things, I think is very important to consider too. Quite frankly, when I was doing this, I really wondered how much I should address his cannabis use disorder and sort of the long-term issue. For the sake of the presentation, I thought I'm not going to do that. But let's just say he continued with cannabis. Well, yeah, then licensed addiction counselors would come involved. It's not really a degree, but a degree that you earn, but you have enough education that you sit for the certification. AA and NA, various treatment facilities. And as you likely know, the overlap, the comorbidity between substance use disorders and other psychiatric disorders is huge, there's actually a thing happening now where people with schizophrenia are using methamphetamine, good old meth, right? People are calling it methaphrenia, which is it really makes for a bit, as not surprisingly, makes for a pretty bad prognosis is having those two together. So that's another big issue of how the substance use problems get into everything else, frankly. And of course, here's all the different public health essential services. So hopefully that gave a pretty good idea of what this looks like. Okay, what this looks like. A little bit more on the state-run facilities. This is the structure. The state hospital, again, full disclosure, my wife works there. They get a lot of admissions. We talk about the ideal of having people treated in the community, which I think is a good idea. I think it's a great idea. And we will never get rid of the state hospital. There's this idea that we should shut it down. And I don't know how much people think that's how good of an idea that is or not, but to me, it's sort of akin to shutting down intensive care units for cardiac disease. They're better treated in the community. Well, no, they need an intensive care unit. Montana State Hospital is basically the intensive care unit for psychiatric illness for the state of Montana. It really is. So we're going to need to have that. Can we improve the community? Yeah, we sure can. Yeah, we sure can. Now, this used to be the developmental center in Boulder. It's now the intensive behavior center that got essentially not closed, but reduced. Mental health nursing center. So again, all these things, chemical dependency, et cetera. What's a big problem with all of them? Right there. And I'll be talking about that later on when I give my recommendations. I'm going to end up with some recommendations on this, but boy, that's a huge problem. I know some group homes are closed because they don't have anybody to staff them. Some psychiatric hospitals are at like 30% capacity because they don't have people to staff. It's a huge issue. All right, so any questions on the system before I move on to the next community health issues? I'm not here.
I do have a couple of questions.
Yeah, please.
One is this presentation, is it possible to get it out to local NAMI affiliates?
Oh, of course. Yeah.
And also, I'd like to suggest that if a community has a counselors association, that they see it as well, so that they sometimes psychotherapists don't understand the system beyond referrals to their offices, and this would be huge, especially in terms of how they might work with PAC teams and mental health centers.
That's a great idea. I like that idea. Yeah, that's a great idea. So, and maybe like family physician as well. I think they sometimes don't know the overall system.
Yeah.
Good. That's a great idea. So primary care docs. That's a great idea. So yeah, this might just have to give this talk in other venues, I guess is what I'm trying to say. Sorry, I sorry, I got sidetracked in that. That's a really good idea. What should we do with that? And so I started thinking about that. So are they public health issues? Any other? That's great. Thank you for those comments. I appreciate that. So the disability adjusted light years, Dallas, they're a huge contributor to that, especially if you include substance use disorders. If you include the dementias, Alzheimer's and whatnot, it's even more. So about 10% of them worldwide is due to this, and about 15.7% in the Americas, so essentially North America. So it's a huge contributor to overall disability adjusted life years. People who have mental illnesses in general die about 20 years younger than others who don't have, and that's not just suicide, that's just death overall. In some estimates, and I think some of these are frankly conservative, 20% of people will have a major mental illness at some point in their life. So that's another. So again, yes, very much so. They're public issues. I like to say public mental health. This is a concept I'm trying to get out there for many people. Suicide is the leading cause of death. I have a section on that I'm covering. It's they have to cover suicide, which is a issue in and of itself. I have this idea that if it's in the DSM-5, the Diagnostic and Statistical Manual 5, it's a mental health thing. So I'm just going to use that as a criteria. So cigarette smoking, nicotine use disorder is a huge cause of death overall. It's the leading cause of death, right? Because strokes, heart disease, cancers, COPD, cigarette smoking, and about 95% of people with schizophrenia smoke. Fairly high rate of smoking and personality disorders. So people with psychiatric illnesses have a higher degree of smoking. Oops, excuse me, I have a dog at the door. Come on. My apologies. Big dog, get away, and he's going to need treats. This is called my life during COVID. So I was kind of hoping you wouldn't come out. I was kind of hoping that. That's okay. You get to see my big dogs. And they're big dogs. So, I got four in the chat. Maybe I'll just click on the chat here. You know, I can turn on my phone. So as I'm kind of going on about that, definitely, you can, as you can see here, cigarette smoking is a big part of all this. You want to just sign in here too, so I can see the chat. Sorry for the delay. No, that's not gonna work. Yeah, that's not gonna work. Sorry about that. A little bit. So kind of continuing on again, if it's in the DSM-5, I consider it something we can talk about as mental health. We'll talk about this a lot down the road. Yeah, cigarettes cause a problem, alcohol a little bit too. There's some problem with alcohol. Again, that's part of mental health. There's a lot of overlap, a lot of comorbidity between alcohol use disorders and other mental illnesses. Opioids, you might have heard we got a little bit of a crisis with opioids going on. That's a huge public health issue. Nationwide, it's over 100,000 people have died of opiate overdose. It's relatively high in Montana, although I've heard from a person who is an EMT that the fentanyl is going down in Montana. I'm going to click on the chat to see if I can see any of them here. So try unmuting again right here and ask you. Yep. So Aaron, yeah. So Aaron had most of. Okay. Want to make sure I get everybody covered here. So now we're going to go into some what I think I would call common etiologies, common exposures that go for both physical health, chronic health, and mental health. In particular, of course, adverse childhood experiences. I call these John Snow's pump. Now, if you might be familiar with John Snow, he's a public health hero. He was in London and basically found the well, a water well that contributed to a cholera outbreak in London. Now, they did not know what cholera was, right? They didn't know what it was, but he found it and took off the handle. So I call ACEs his pump, the cholera. And what do they include? Physical, psychological, and sexual abuse, neglect, family violence, family mental illness, incarceration, and it's dose dependent. I think it's greater or equal than 4. You start really having a lot of medical issues. They don't change DNA, they change the expression, the epigenetics. And I'm going to try this. This is a video that really sums up what adverse childhood experiences do. So let me see if this will work. It looks like it's going to work. I'm very happy about that. Okay. This is from the Neuroeducational Institute. Are people seeing this okay?
No.
No, we're not seeing the video at all.
Okay, so I'm gonna have to unshare. How about now?
Yes.
Yes.
Didn't get what I needed. Young. The fear from my past, I carry it with me. Can I ever recover from what you've done? 'Cause
This is a mechanism of action. That's the brain activity behind it.
You ruined me. Nothing wrong with ATGC.
DNA itself doesn't change.
Just a broken memory chain. It's killing me. You, my expression of my you ruined me.
I kind of cry every time I see that. Let's get this go away. Yeah. Sure. That is a good demonstration of how this how the ACEs work. I'm sorry, that always kind of makes me upset. So anyway, so that's the epigenetic of ACEs. Again, this is the common etiology that I would say. And as we go along with that, there's historical trauma and intergenerational abuse. ACEs tend to perpetuate themselves. You know, that's again something to keep common etiology. And they increase the risk of, it seems to me, this is probably more of my bias, that people tend to look at the mental illness side of ACEs because it seems that makes more sense. But they have increased risk of everything else: stroke, cancer, diabetes, all the medical ones. Separate from the people with ACEs also might smoke more, but these are separate from that. These ACEs themselves have more than just the increased risk of cigarette smoking with all the other illnesses. So I'm not necessarily going to go into all the interventions, kind of keeping my time aware here, and we're going to take a break. You know, I thought maybe like 9:55 to 10:05, about maybe somewhere in that range, 5-10 minute break. But there's a lot of them. Anna Bradley for the state is doing a lot of work with the adverse childhood experiences. And you can have positive childhood experiences, which I think is really pretty cool, that just a few positive experiences really helps mitigate the risk of adverse childhood experiences. So feeling supported, having some adult, non-biologically related adult take care of you will mitigate, again, a lot of the problems of ACEs. So supported by a friend, feel safe and protective. Those positive childhood experiences, I think, are really something to keep in mind when it comes to adverse childhood experiences. So this one I have quite a bit on suicide. I kind of give you a little bit of back history on this. This is back history of this of myself. I've been part of suicide prevention coalitions and whatnot for quite a while, including on a panel. I was on a suicide prevention panel that would speak at various organizations and conferences and whatnot. And the night before I was supposed to speak in one of those panels, the suicide data came out. This is in 2018. It came out from 2017, and the rate's gone up again. It's gone up. So it occurred to me that we're not doing well. We're not doing well. What am I doing? So I went back to at a spry young age of 59, went back to get my master's in public health, mainly for this reason. It's a leading cause of death, as you all know, especially in younger populations and various other subpopulations. And so even though people will say it's a rare event and we can't study it, I think that's a bunch of malarkey. It's a leading cause of death. So we'll do it in the chat here. I'm going to make sure that I keep monitoring that. Oh, there we are. Okay, never mind. So demographics, okay? We tend to think of suicide, we worry about with teenagers. Obviously, that's a big issue. In my master's thesis, I looked at suicide death certificate data, and the youngest was 11. There's two people 11 years old. in 2014 to 2019 who died from suicide. And so youth is one for sure, but also there's, you have to think about young. Well, when you look at suicide, it's not just like one thing. It's more like cancer. We try to cure cancer. Well, which one? Right? The treatment for lung cancer is a lot different than treatment for, leukemia. Suicide is more like that. So it's more like that. You have to look at the different phenotypes of suicide. So, so there's young Native males who die from hanging themselves. Adult male, also male Caucasian males who break up with their girlfriend or whatever, get drunk and shoot themselves. That's another type. The elderly who are in chronic pain, another type. LGBTQ, feeling oppressed, another type. So, person with, woman with borderline personality disorder who continues to have suicidal ideation. So when we think about suicide, I think it's really important for us to know that we're not talking about one thing. We're talking about lots of different, I think cancer is a better analogy for it. There's lots of risk factors. Again, I started looking at my time. I got quite a bit more that I want to cover. So I want to make sure that I do that. There's a lot of risk factors, as you probably know. So what do we think about with prevention? Okay, in a public health sort of a way, we have primary, secondary, and tertiary prevention. So primary, and I'm going to go backwards, basically. I'm going to go backwards. Tertiary is when somebody's in treatment, right? They're in treatment, they're seeing their psychotherapist, they're seeing the physician, that kind of idea. So they're known to be suicidal, be depressed, whatever, and they're in treatment. And there we do know that there are some medications, lithium for bipolar disorder, for example, clozapine in particular for schizophrenia. Lithium's for depression too, by the way. If you give someone with lithium for depression, that decreases their suicidal again. When some of the easier to take antidepressants, the earlier ones were pretty hard to take, had a lot of side effects. But one like Prozac and some of those, a lot easier to take, were prescribed a lot more. Suicide rates went down. Once they started, where all the sort of hubbub, if you will, came out about them, they weren't prescribed as much, and sure enough, suicide rates went up again. So they were going down in the late 1990s, and they're going up again in the 2000s. And some forms of psychotherapy, cognitive motivational interviewing, those are all been shown to decrease suicide on a tertiary once they get into care. Secondary, you screen. Okay, you're screening for cases. You have blood pressure checks. You have diabetes checks that are kind of in the community. That's what this is for suicide. In particular, what we do is we have the gatekeeper trainings. So this is QPR, QPR, and assist for the most part. There's others. I just focused on those two with my masters because they're done a lot. They're done a lot. There's other ones as well. So what do they do? What do we know about them? They improve knowledge and the confidence around suicide. There are data, there are studies looking at that. They do that. And here's where I might get a little bit upsetting for folks. They've never been shown to prevent suicide, never. They're called suicide prevention techniques, but they've never actually been shown to do that. So frankly, this kind of bothers me. It's like we call them suicide prevention, and there's no data at all to say that they do. So again, going back to my master's thesis, what I did is I looked at gatekeeper trainings in 2017 and 2018, mainly because I had a lot more data on them for those 2 years. And I'll talk about how I got these 13 points later. So this is a Montana suicide assessment regions. I'll show you what those are later. It's Montana. It's basically the DPHS health regions and what I call urban counties. So this is non-parametric, a bunch of statistic stuff here, but I don't need to go into that. But just say, people will say they can't measure it because there's not enough population. I counter that, say, is this a good measure? It's not as good as you might want for larger populations. But what it does with this kind of statistic does, it's more like clinical, right? It's not so much science as it is clinical. This is more like, when you go to the doctor, they say, this medicine's not working for you. This medicine for you. So is it looking at large populations? No, it's not. It's looking at more what I would call clinical, the local population. And here, looking at how many, trainings per 100,000 and how many suicide rates per 100,000, it's as non-significant as you probably can get. Okay, that's about as high p-value as you can get. So it's really not related at all. And here's 2018, same sort of thing. same sort of idea. So even though we have these gatekeeper trainings, and again, I know this might be a little bit controversial, we do these gatekeeper trainings as a matter of course as public health to prevent suicide. They've never been shown to work. I just said it. They've never been shown to work, and why? I think it's going to be a bit of a strong statement. I think if we continue to say they're for suicide preventions when we know they've never been shown to do that, that's a pretty major problem in my mind. That's a really major problem because we're doing something that ostensibly does treat this, decrease this, and it's never been done. So I have deep concern about that. So what do we do? Well, how about primary? And what do we do to actually have suicide not arise in the first place? There's this interpersonal theory of suicide. So this bases our interventions on theory. It's interesting to me as I've looked into this issue of suicide, how much our prevention efforts are not based on theory, and how much the theory and science of suicide doesn't really look at prevention. It's just, I mean, that's a bit of an overstatement, of course, for presentation here, but not much of an overstatement. It's like, how come these aren't sorted together more than what they are? It's befuddling, I guess. It's befuddling to me.
Dr. Mann,
Yes, please.
you have a question in the
Yes.
chat. So how was success measured? And was it number of completed suicides?
Oh, here. This is death certificate data. So in our death certificate data, a perfect measure of suicide? No, they are not. Are they a measure of suicide? Yes, they are. So this is people who died from suicide. That's how that was measured. Does that answer your question?
Sorry, it does. Yes, thank you.
Okay, thank you. Yeah, good question. It's hard to measure. Like that's so to have basically my argument for this is, yes, it is hard to measure. And I love the phrase, don't let the perfect be the enemy of the good. It's hard to measure, but we can do that. And it looks like Jessica Gilbert raised her hand. Go ahead.
Hi, thank you. Would it be fair to say though that these things, these trainings such as the gatekeeper training, that they help they help towards the prevention piece, right? So we know that we know when it comes to suicide, the reason why they push weapon locks is because that's a guaranteed, right? You put a
Right.
weapon lock on a weapon, it's guaranteed it's not going to fire. So we can't necessarily guarantee that one gatekeeper training is going to prevent suicide, but we can definitely say that it's an added piece that's going to help towards that prevention, right? Because there's so many different factors that go into suicide. You
Right.
can't say that one specific regimen is going to prevent that suicide. Would that be fair to say?
That is fair to say. That's exactly right. And we do know they improve knowledge and confidence around suicide. So to have the gatekeeper be that part of the overall system of suicide prevention, absolutely. I don't think we should, as one friend of mine said, let's not throw out the baby with the bathwater. I don't know if that metaphor works out completely well, but yeah, I don't think we should stop doing them. I think we should know what they do in the overall system. Desiree has a hand up.
Yeah, a question in the chat. Sorry if I missed it, but have you defined gatekeepers?
Oh, gatekeeper is basically the idea for secondary prevention that you ask about suicide, that you notice signs of suicide, the different behaviors that people can show, giving away things, drinking more, talking about suicide. Then they're the gatekeeper to getting that person into care. Okay, that's the why the gatekeeper is used. And that's the common terminology for the assist, and there's quite a few other, but assist and QPR is ones I looked at because they're the common ones that are used. So that's gatekeeper. They like keep the gates, if you will, of noticing that someone might be suicidal and then talking to them and referring them to care. And it might be, QPR is question, persuade, and refer. It might be VR, that there's no place to refer to. I mean, that could be the problem with why they have never been shown to prevent suicide. So should we throw them out completely? No, we don't think we should. We just should know that they've never been shown to prevent suicide, and take it from there. Excuse me. That makes some sense to people. So again, I thought this might raise some questions. Let's raise some questions. So this is me speculating quite a bit coming up, and there's some more people in the chat. I don't know if again some questions come up for that.
I think they're messaging you directly. I don't see them.
Oh, okay, okay. So there's quite a few theories on suicide. They all have quite a bit in common. Even back to Durkheim, who was a sociologist from the late 1800s, if I remember right. They had more things more or less in common. It's thwarted belongingness. So something happens that you feel like you're no longer a part of the community. You think you're a burden, that people would be better off without you. That is another aspect of it. And then capacity. Capacity is not just access to weapons. It's also the mental state of this is something I can do. Okay, I can die from suicide. So how do we get that theory into a preventative system? I don't know. I think I don't know, but I think we need to consider that basically. And there's some culture. I mean, I think Montana and the other mountain states do have a culture that is around suicide. I wonder if it perpetuates itself. Because if you know someone who died from suicide, you're more likely to attempt suicide yourself. So most of us know someone who died from suicide. I wonder if that just perpetuates itself, sort of this ongoing contagion of suicide, and kind of switching my metaphor from cancer to contagion with suicide. I think we need, this is what I'm considering, is we need to have different ways of looking at it. So kind of getting pretty close. We'll cover this one. By the way, just more quickly on this. So some of my students, pretty interesting, because this is happening organically. This is really not from my impetus at all, but I talk about suicide, obviously it's an interest of mine. And these are out of high school students, just fresh out of high school, or college students. And they talk about the suicide prevention they got in high school. Fascinating the way they think about it, not the way we would like them to think about it. How about that? Tomorrow, there's a suicide survivor conference at the Capitol, and we're going to be presenting. My students have some pamphlets they're going to hand out on this. So I've heard this last weekend, there was a conference, Large Neuroeducational Institute, that's where that video came from. And they talked about loneliness as the current pandemic, that kind of getting away from the COVID thing, but the loneliness is the current pandemic. It's really worldwide. It's a pandemic. They looked at South Korea, who has the highest suicide rates, Japan, Australia. It's worldwide. And what does it do? It does a lot. Again, this is a common etiology between depression and anxiety and suicidality, some mental health things, but loneliness itself increases the risk of diabetes mellitus, obesity, and it's an independent risk factor for heart disease that has as much of a risk as smoking, as family history, as lipids. So loneliness. And can we treat loneliness? Possibly, actually, yes. Sleep disturbances. If you have decreased sleep, that increases your risk for all kinds of trouble, including Alzheimer's disorder. So this loneliness idea might be contributing to the huge public health problem of Alzheimer's. So what a fascinating place we might be able to make some kind of intervention is the loneliness. Decreased general well-being is one, and of course, mental illness and COVID-19. Yeah, of course it went up. So we're at 9:55. This is probably a good place to see. How about, let's finish here. We'll finish with this one because that we go into another section. The gut microbiome. Again, sort of common etiology. Wow. I mean, the bacteria in your large bowel, in your small bowel, the bacteria there influences all kinds of stuff, not just stress, anxiety, depression, schizophrenia, again, cognitive decline, dementias, autism. There's some cool studies looking at autism spectrum disorder and the gut microbiome of it. And then, wow, all this other stuff. All these axes, right? You have endocrine, heart, lung, liver, pancreas, bone. Bacteria in your bowel have so much to do with all the rest of your health. So that's another common etiology. eat yogurt. I make sure I eat a fair amount of yogurt because that's one of the best ways you can make good bacteria in your bowel. So any questions on this one, the gut biome, microbiome? It's really fascinating. A lot of work is coming out on it, taking a look at all these different bugs in your bowel and how much it has to do, not just with psychiatric illness, but all the physical ones as well, and to have good bowel health. Okay, well, how about if we stop there and take how much, about usually like a 5-minute break, maybe? What's your routine? Welcome back. Welcome back. So, hope everybody had a good break, got the legs stretched out. I have to give you a warning. One of my dogs is starting to whine. He whines a lot. So if he whines in the background, I apologize. I apologize. And this has been my life for the past 2 years, frankly. So addressing community health, chronic disease, had to change color here. Don't want us to keep it red the whole time. And of course, ACEs, revisited. We just want to make sure we focus on that because I think it's a huge issue within our overall system. Not going to be an easy one to get on top of, but very essential. So so yes, Desiree. Oop,
In the chat, somebody had asked, you listed Montana Mental Health Nursing Center. Can you please describe that a bit, please?
Oh, okay, yeah. So Montana Mental Health Nursing Center is in Lewiston. And basically, it's a place where if you have a dementia or other sort of neurocognitive problem, you'll go there. So it's not just a sort of your usual nursing home that are wherever around the state, many of which are closing, unfortunately. But it's more for people with mental illness and who are elderly and demented. So it's a particular place for care. It also is understaffed, and it's a difficult situation there as well, as it is almost everywhere. And is that a good enough description? Does that answer the question?
That is. I'm just gonna catch up with that for a second because I asked the question, but what is interesting to me is that certainly dementia could be considered a mental health concern, but it is usually not included somehow as a mental health concern. And in some respects, it's confusing because, as you just said, the people that might be served in Lewiston would be most likely to have dementia, but may have other types of mental health concerns.
Yep.
I'm not sure if you meant strictly that they will have other types, comorbid mental health concerns, and I guess just in general, it's a very interesting issue because when we discuss mental health care in a community, we don't usually talk about dementia as one of those, populations or those concerns in the community. And if we do, it can be quite distracting, I'll be honest to say, when it comes to talking about things like schizophrenia or a substance use disorder, because the umbrella gets so big. So it's just a concern that way.
So
Thank you.
concerned that if I were to, so maybe they should not be included in discussion of mental illness?
Well, I have mixed feelings about it. I'm ambivalent about it because it seems like, yes, it should be discussed as a mental illness because it is a mental illness, frankly. But it is when a community group tries to address, a public health organization tries to address mental health in the community, they have so many populations to address, and the interventions are so different that it becomes extremely complex to figure out what can a community do, what can a public health department do, where should they address, which concerns should they address?
Yeah,
Substance use disorders versus there's so many resources, there's only so many resources, and then which ones are the highest priority? Adolescent populations, substance use disorders, et cetera, et cetera. I could go on and on.
Yeah, no, I absolutely agree. And I wish I had a really good answer for that. We also haven't talked about the intellectually disabled. Another large population that would, technically fall under the mental illness in the sense that it's in the DSM-5. And I've just used that as, I need some kind of cutoff, right? Some kind of thing. Okay, we limit it here. But yeah, that's another huge system that I'm not addressing at all, frankly.
I absolutely agree. And I'll just say that the state, one of the departments, I don't remember which department, but it sort of includes developmental disabilities alongside all mental health concerns, if you will.
Yep.
And the fact that they do that, and it seems like there's a lot of resources that are appropriately, I think, headed towards developmental disability cares.
Yeah.
But at what cost? I mean, does it mean that the limited resources are channeled to that population at the expense of all the other mental health concerned populations?
Yep. Yeah. Yeah. Again, I wish I had a good answer for you. Yeah, I don't. My apologies for that. Yeah. No, I do have a thought on that, which I'll get to at the end. Just sort of a granted relatively ill-formed recommendation, but a recommendation nonetheless. So I'm going to continue on. If that's all right. How they're intertwined. And I just picked depression. I could have picked anxiety disorders. I could have picked bipolar disorders. I could have picked quite a few different things with chronic disease. Depression itself is a risk factor, just like loneliness, a risk factor per se for cardiac disease. It influences diabetes mellitus type 2, multiple sclerosis. Again, the question for me here was, what do I not what do I not include? Because there's just so much overlap between these. So it is a chronic disease. And of course, substance use disorders. I don't know if much needs to be said about those as far as their interaction with chronic disease. And again, how do we treat all these individually? It's a really good question. One problem, if I may follow up, is we have the intellectually disabled, people with substance use disorders, people with mental illness. The problem, of course, is the departments don't really address the fact that these are the same people. You have someone with intellectual disability who also has bipolar disorder, just pick one randomly. Someone with schizophrenia who uses methamphetamine, on and on you go. Someone with alcoholism and depression. So, again, I don't know if I need to elaborate too much on these because they're pretty well defined. This one, good old marijuana being legal, we don't quite know the longer term effects that's going to be on our society, but it's certainly more of a concern now. Tobacco, I think I've dealt with enough. Again, just looking at how these are intertwined, they very much are. So just straight up co-occurring mental illness and chronic health. A large percentage, depending on your study, it's like at least 50% of people seen in primary care either are there mainly for psychiatric illness, or it's complicating the care that they have. At least 50%, and I've heard higher than that. Because I teach nurses, for a couple of classes before they go to get into the nursing program, and I really emphasize that for them, that they need to think about that, because so much what they see in primary care is going to have a mental illness. You probably heard this kind of with suicide a little bit again, that a large proportion of people who die from suicide have seen their primary care physician within just weeks to months before dying from suicide. So that's, again, yes. Are they part of chronic illness? In a huge way. So this one, I'm going to go in the other way. So sort of how mental illness affects physical disease. This is how it kind of leads to physical disease for schizophrenia and bipolar disorder, etc. So antipsychotic use that leads to weight gain. Okay, for some, especially clozapine and olanzapine, but others do as well. So weight gain, it gives you diabetes type 2, hyperlipidemia. When this first came out, actually, interestingly enough, people were dying from diabetic ketoacidosis because it wasn't known that they led to diabetes mellitus. type 2. The weight gain was there, but the diabetes mellitus was not known. People were, would die from diabetes. Yeah. So again, that goes the other way, treating psychosis. So here's some that might be a little more broad-based, than, as we think about interventions that might be able to help everything. Including substance use disorders, might actually, well, for dementia, and again, putting it all back into one box. And I'm more of a lumper. You can be a lumper and a splitter. I tend to lump, and that's like a personality characteristic. People can be lumpers or splitters. So in thinking about what we can do to lump things together, exercise helps like everything. It decreases your risk for dementia, helps people remain sobriety. It helps with depression, anxiety, of course, with obesity. Exercise can go across the board, and it doesn't have to be a lot, right? And I think it's like a half hour, 4 times a week or something like that. Not a lot, but that can help like most everything. Diet, a good diet helps again. And there are data to back this up. Again, I don't say anything. If I do say something that doesn't have data to back it, I'll tell you it doesn't have data to back it. It is my opinion, which I don't say much because who cares? It's just opinion. But diet, all looking at the gut biome, right? Good healthy diet, community gardens, all that kind of stuff can really have a common intervention for a lot of these things. Then of course, social support, having people out there for you. NAMI does a lot of good with that. Family to family. There's a lot of other ways we can do social support. So let's switch over to key terminology. I have a few things here that I like to address. So one thing is the term evidence-based, and I'm probably a little bit biased on just the way I think about evidence, the way I think about things in general. But I worry that people say it's evidence-based, translate that into it works. That ain't necessarily so, to quote Porgy and Bess. That the evidence for something may support its usage in various ways, and I'm not just going to focus on the suicide interventions. There's other things along that line as well. So we just need to keep that in mind when you hear the word evidence-based. That what is the actual evidence that we're basing this on? Does it really support it as far as like, while we're doing this, it is going to work? Well, maybe. Zero suicide is another one that it does have evidence that it works, and there's some parameters around that, and that goes for everything. That really pretty much goes for everything. So it's a concern of mine that we translate evidence-based to it works. It may or may not actually do that. It might help, but so just to kind of keep that in mind. And what does it mean? Translating research to clinical. Antidepressant trials, to show that they work, okay, yeah, they'll have to have about a 50% reduction in symptoms in 2/3 of the patients, where a placebo does that in 1/3. So antidepressants are a very valuable tool, okay? Some people, they save their life, and they don't always work for everybody. There's some populations that I don't necessarily need to go into those now that do better on antidepressants, and some who don't respond to them as well. Early childhood abuse, for example, will decrease the probability of you responding to any particular antidepressant. We also need to think about, I'm covering a lot of issues here. I hope that's okay. I guess it was quite the talk to consider. There's Alzheimer's treatments. Now, let me do something different than that. So for Alzheimer's, there's some medications that we use to treat that. And, maybe you'll get demented this fast without the medications, and get demented that fast, so a little bit slower with medications. Does that make any difference to the people who are caring for the folks with Alzheimer's? Maybe not a lot, because they still do get demented. Again, keeping that in mind, the difference between statistical significance and clinical significance, those are not the same. We need the stats, we need the science, but then applying that to clinical, that makes a big difference. Again, kind of referring back to my day job of teaching, I actually recommend people not take my research methods course and my abnormal psychology course at the same time, because it's such different ways of thinking, the science and then clinical. So, but it's just important, again, to keep in mind what evidence is and how it translates from antidepressants to what actually happens. So here's one that I'm going to, I just had to put this in there. It's actually not tongue in cheek, but a little bit it is. Don't say chemical imbalance. Just stop saying that, because it doesn't make any sense. We talk about serotonin and norepinephrine, particular serotonin, as being imbalanced, and we think serotonin's involved at all because we happen to stumble upon it with medications. Medications came out that treated depression. We didn't know how. We went backwards, kind of, reverse engineered them to see what they did. And it turns out they acted on serotonin, norepinephrine, and dopamine. There's a bunch of other stuff too. Okay, it's far more complex than that. We just happen to fall upon serotonin with medication, so it doesn't make sense. And I really just don't. Okay, just don't. They're highly complex. Do say neurocircuitry or brain pathways. Any of those are fine. Any of those are fine because that's really what we're looking at. Those are where the symptoms get made, is in these pathways, not with particular neurotransmitter, but the overall circuitry. So if you say pathways, it's just going to make a lot more sense. And I think it's going to help people understand the relationship between symptoms and treatments, and why medications can treat both different kinds of target symptoms, and psychotherapy can too, why these different modalities can treat the same thing. And fortuitously, again, last weekend with with the conference I went to, they had some pictures of systems. So I thought this was quite fortuitous, and I thought put them in here. Central executive. So you have trouble with that. ADHD, poor working memory, disorganized, indecisiveness. So the prefrontal cortex. We don't need to focus on the actual neural structures per se, but I think it is worth just thinking about circuitry once again. So that's what's going wrong. It's not a serotonin imbalance so much as it is this overall system. Default. Okay, this is where we have a sense of self, a sense of independent self. So when that is abnormal, so all this theory of mind instead of self-reflecting, you now have wandering, worry, social dysfunction, you ruminate, you have all these, again, symptoms, symptom clusters, target symptoms for treatment modalities of whatever sort. And just some more. Volition, regulating emotion. There's quite a few, a lot of mental illness per se is regulating emotion, right? So that's again, don't say chemical imbalance. If you find yourself saying chemical imbalance, remember this talk, remember these cool brain pictures here, and talk about brain pathways, neurocircuitry, because that's really, if you conceptualize it that way, it makes a lot more sense. So low motivation, okay, anhedonia, negative emotions, anxiety, and depression, salience, what's important to you. So again, these are terminology that I really hope that we can start using, because it's more indicative of the underlying pathology. All right, so how are we doing? So going on to key terminology, a thing that I hear quite a lot, of course, is we need crisis stabilization, which we do. Okay, we do. And what is that? What is crisis stabilization? We kind of have an umbrella term for that I don't know if we really think of it individually enough. What does it mean? So, there's people who have personality disorders, which I don't cover too much in this talk, because again, there's just a lot of things to cover, but they become suicidal, and they get out of that sometimes pretty rapidly. So, okay, that's a crisis. How about a young man who just broke up with his girlfriend, starts drinking and becomes suicidal? Yep, that's a crisis, a little bit different from the one with borderline personality, right? How about Mel? He got psychotic again, having a relapse. Yep, might take a little longer to treat. Hopefully antipsychotics work well. And then someone just overwhelmed. They just are not dealing with life. They just need some help for a short term. Is that it too? And I could go on. My point here is, when we're thinking about crisis stabilization, what are we talking about? Okay, what all needs to go into this? What all is similar to, I don't know. We need a medical ward. Okay, for what? Well, we need a medical ward for asthma, for cancers, for infections. We need to look at it in this sort of broader term. And what does stabilized look like? Again, I think they need to be better defined, and as opposed to just saying crisis stabilization. How many times have we done this? A lot. I've been here for a while. I was thinking about this talk, at least 3 times we've tried some kind of crisis stabilization house. I think 4 and they don't last. Then that's just Lewis and Clark. So what goes wrong with these as we're developing the system? Again, this is coming back around again, right? Crisis stabilization. One of the main things that go wrong that I've seen is, of course, staffing, because you need to have these folks in these places staffed 24/7, and you may not have patients 24/7. So you're not going to break even on these money wise. You're just simply not. So that has to be kept in mind as we once again start looking at crisis stabilization. So medications, I want to get to, this is one that gets addressed sort of among the psychiatric and nurse practitioners, but I think it's worth looking at. So again, here's some neurocircuitry. There's a type of medication, atypical antipsychotics, which are prescribed a lot. They're prescribed a lot because they're good for schizophrenia. They're indicated for schizophrenia. If someone Googles, they go to Dr. Google when they get prescribed, Risperdal or something, they'll say it's for schizophrenia, which it is. And it's used for a bunch of other stuff too. So that gets confusing. Why am I getting an antipsychotic when I'm depressed? Well, this is why. This is a little cartoon representing these medications. And each of these little things, that's serotonin, that's dopamine, there's norepinephrine, there's histamine. It's just a cartoon displaying them. The metaphor that's usually used, which I think is kind of fun, is what are these? What is this thing that I have here? What is it? Is it a phone? Is it a computer? Is it a calculator? Well, it's all those things. And that's similar to what these medications are. So taking it from the title, the name, antipsychotic, to no. What do they do? And where do they fit into that neurocircuitry and all the different neurotransmitters? And I just tossed out a couple. The pips and the rip. There's pings, dones, pips, and rips. Here's the two pips, and there's the rip, cariprazine. So again, this is just an example of these different medications and why an atypical antipsychotic works for bipolar disorder, works for depression. So that's the idea there. So psychotherapy, and please excuse the bananas. I use bananas as my example. How brains work. Okay, again, we'll get to getting rid of the mind-body problem just pretty quick here. So if we think about how cognition works, so when you see this, do you hear it? Do you hear yourself say, yes, you do. That's the phonological loop. Well, that phonological loop can also have negative cognitions about myself. Okay, that's called cognitive distortions of depression. That's what it is that loop. Visual spatial sketchpad. Can you imagine, can you sort of see those bananas wherever you keep bananas in your house, in the store? You're getting images of that as we're talking, right? That flashes in your mind. Well, that's what flashes in your mind when you're depressed and anxious. You'll have these sort of visual images that get distorted. So my thinking here is, if we can translate these psychotherapies into this is how brains work, they'll make more sense. They make more sense, and therefore it's like, okay, they actually change the way our cognition. And here's some other ones: schemas. How do we view the world? How do we view ourselves? Okay, our schema about how ourselves, et cetera, et cetera. And there's various types of psychotherapy. Not all psychotherapy is created equal. DBT, for example, has a lot of evidence for borderline, but others as well. Motivational interviewing for start off with substance use disorder, but other things. Cognitive behavioral therapy, as one student said in my abnormal psych, if you put cognitive behavioral therapy as your answer, you will not get it wrong. It works for you change your way of thinking and your behavior. So I thought it was, as we're looking at key terminology, I thought it was worth throwing out there what psychotherapy does. What is it, compared to what the brain is? Diagnoses. How do we make a diagnosis? What does this even mean? Well, meet criteria. The DSM-5, basically professionals, scientists, clinicians get together and say, this is a thing. Okay, all these symptoms, we're going to call it this. And that, for the most part, works. It gives us a common language that when I say, pick one, schizoaffective disorder, you know what I mean. That's the idea. But we then have some vague ones. Unspecified psychotic disorder. What does that mean? Well, anybody has a hallucination, so you can have that. One that disappeared is ADD. That no longer exists. It's now attention deficit disorder, predominantly inattentive type. Actually, there should be an H in there. Predominantly inattentive type. Maybe that's a disservice because there's people, in particular young girls, frankly, who may have just the attention deficit part, not the hyperactivity, and they won't necessarily get treated. Desiree, yes.
Question in the chat.
Uh-huh.
What happens when you have no resources in your county?
Huh. Can I get to that?
So that was a few slides back when you were talking about, you know, the boy, yeah, keep going. Nope. Oh,
Keep going.
about the teenage boy that was suicidal,
Oh.
was drinking, that slide right there. What happens? And maybe you'll get to it.
Where we at? Was the crisis?
Yeah,
Crisis stabilization?
Must have been, yeah.
Went too far for it. Yeah, this slide then. I mean, I have some ideas around that.
perfect.
I don't know if they're great ideas. I'll just kind of say that. But I do have some ideas of what we might be able to do when there's no resources. Because Frank, bottom line is we're probably not going to get more resources. We're not going to get enough psychiatrists or advanced practice registered nurses. That probably just isn't going to happen. So, so what can we do instead of? I have some ideas that do have evidence in other countries, frankly, that we might be able to incorporate into Montana. And we're starting to do that, but I think we have a ways to go. But yeah, I mean, that's a big
And are
problem.
all these resources supposed to be done by public health?
Oh, no. So
Perfect.
I think you can define public health, and one of the reasons that I really like it, and I'm trying to get a program at Helena College, is it's pretty broad, right? It's a pretty broad way of thinking about things. So, if you throw in public mental health, having facilities to treat this population publicly, right? It's out there. Yeah, it's kind of public health. I would call it public mental health. So not necessarily the public health department of a county, not necessarily that, no. But maybe. Frankly, I think there's a lot of work it's actually my last point. The slide is some work that needs to be done in order to, I think we can do this, but we have a lot of room to move. I mean, we're still here, right? We're still at this place where this is a fairly major problem, not even fairly major. So we're still here. Therefore, if we did have a solution for this, we wouldn't be here. We wouldn't have this. We wouldn't have this conversation. So I don't think it's known. Okay, I don't think because it's not just Montana, right? This is not just unique to us. So I don't think we really knew in a sort of a larger picture of things what we're supposed to do. So yeah, what do we do without? I have some ideas. Let me get to them. So that's just for everybody's. Yeah. Some of this seems okay. Desiree, yes, again.
One more in the chat. Tell us more about crisis stabilization in other countries.
Other countries. Yeah, sure. So I'm going to do a quick. In my classes, I have a thing called Stump the Chump, and that game, I call it a game, is if somebody in my students asks me a question during a presentation, and I don't know the answer to that, I'll say, go to the scientific literature, see if you can find it, bring it back to me. The chump is stumped, and you get extra points. So you're not going to get extra points. So let me think about that. I do know that some of the European countries have more. I mean, their suicide rates are kind of going up too, but they have more. They have more public, right? They have more of a socialized, to lack of a better term, system, so they can monitor things quickly. I think Italy actually. Italy puts a lot more resources into their mental health, and they have. Is it crisis stabilization per se? I don't know. I don't know if that's the term. I haven't looked at that crisis stabilization in other countries. So I just know other countries, it varies a lot. I mean, some countries like, I'm going to talk about India, have even less supply of providers than we do. And it's a lot more people. So yeah, I don't think I can really say what, I don't know, Brazil has for crisis stabilization. I know some of the I don't know suicide better. I know some of the Islamic countries have very low rates of suicide. And some of the, some of the Asian countries have fairly high, and then Eastern European. So some of those I know. Crisis stabilization, I apologize. I just simply don't know. And Desiree, yes?
He goes on to say, my impression is that Montana hospitals are reluctant to assume the provision of comprehensive crisis stabilization services.
That's my impression as well. Maybe I should, well, wonder if I should skip forward a little bit, because I'm going to skip forward a little bit. This one, yeah, okay, that's not that much further actually. Yeah, let me get to that. This was sort of at the end of things that I just said the word in my impression, and I'm embarrassed. I'm like literally embarrassed for saying my impression, because we get too much from impressionistic, and I'm going to talk about what I think we need to do as far as going from it's my impression to what's actually going on, because I would bet that hospitals would say no, we do too. I know St. Peter's has a fairly large program that do. They have they're taking on zero suicide. They do some of the crisis stuff. So yeah, I don't know, and that's let me get to that, and then maybe that'd be a place that we can open this up even more for what the heck are we supposed to do. Suicide terminology, I'm going to have this a little bit. Most of the things I think people already do. I mean, we know what suicide is, what suicide behavior is, suicide attempt, non-fatal injury, with intent to die. Okay, thinking about it. Survivor, lost survivor, that will be tomorrow. Looking forward to that. Lived experience, one who attempted and survived. Your own experience. And the key one that I'm going to bring up, you don't say committed suicide, don't say complete suicide. I know those are common. You certainly don't say successful. It's more clinically accurate to say died from suicide. And people argue, well, suicide is a little different. And I'll argue, no, it's not. So do you say someone committed a heart attack? You say someone, completed cancer? You don't. You say you died from that. So, and this is not just me. This is the suicide prevention. I got my books in the Henry here. That's the American Foundation for Suicide Prevention. So this is their recommendation. This is not just Nathan's. This is their recommendation. So in my view, saying they died from suicide decreases stigma, right? Decreases stigma. It's committed, like you commit crimes. People, use that as their example of why you shouldn't use it. But so I think it decreases stigma. It puts it into, oh, this is a health thing. And the person who was talking about before, how we have this all divided up, I think this puts it together a little bit. So that's important key terminology, I think. So here's my recommendation. So, and I can go, I have more now, right? I have more just from this talk. We closed the Montana Developmental Center. Where did they go? Have we tracked? And this is the tracking part. This more here, data systems. Do we know where they went? I think some of them went to the community. I know, again, some of them probably went to the state hospital. Some are probably in jail. Where did they go? We haven't, if someone has an answer to that, I would love to hear it. I would love to hear it, but we don't follow up on that. I think it's a problem. Are the demented patients, that's getting back to that psychosis not otherwise specified. Again, I have my full disclosure, there's people in their 80s getting admitted to the state hospital. What's happening there? So, and again, we need to move from anecdote. Okay, that's a nice little story. How many? Where are they from? Et cetera, et cetera, et cetera. We need to get a handle on this. So this is what I did for my, kind of going back to that evaluation part, because we needed to have, what I've never seen is ability to, well, how is this thing working? How, we talk about implementation. We don't do as well with evaluation in my experience. So to do that, you need something to compare. Okay, I need to compare this to that. We need variables, right? It's a science thing. We need to have variables. So what I did, and it's somewhat arbitrary, but I think it works. The 5 DPHS reasons, which are shown here, 1, 2, 3, 4, and 5. And then I divided up into the what I called urban for Montana. Micropolitan it's called, micropolitan, it goes down to 30,000. And I mainly wanted to go down to that, so frankly, I included Butte. So I got those eight urban ones, 5 ones, and I used those as my comparison for the suicide. But those could be used for anything. You know, St. Peter's is implementing the zero suicide. It's this thing that's just started. I think other places have it too. So okay, let's look at it here. Let's look at it here. See if anything changes as far as whatever you want to measure, suicide rates, hospitalizations, whatever you want to measure, and compare it to these others. These are called quasi-experimental. You know, we do one here, compare it to there. Did it work or did it not? Interrupted time series. So we started, you know, pick one. This, let me go to long-acting injectables because I like that idea. We've got the Billings Clinic doing long-acting injectables right away, and does that then decrease hospitalizations to Montana State Hospital? I don't know. You know, so maybe, but that's the idea, that because again, what do we do about this? Well, I think we need to get a handle on it. And of course, we need community-based participatory research. Everybody needs to be involved in this. We need to go, you know, and when I look at, when I see counties evaluated saying what they need healthcare wise, what comes up often to the top? Mental health, behavioral health, whatever you want to call it. So we really need to get the communities involved in this. This is a thing, right? This is a thing. There's structure behind how to do that. I have a book on that one right over here too. How you do good community-based participatory research. You don't do research on people, you do research with people. That's the biggest idea. And then how do we monitor stuff? How do we monitor health? Can we get a centralized data? Are death certificates enough for whatever we're looking at? Are you know, Medicare and Medicaid utilization, are those enough? Whatever it might be, but to have that data somewhere centralized that you can start asking the questions. Oh, okay, here we started this program here. What happened to these variables over here? Did that work or not? And then we can start saying, as opposed to it's my impression, you know, hospitals don't, state hospital to whatever. No, what is going on there? I feel pretty, obviously you might pick up, adamant about that. And here's some of the ones to what do we do if there's no providers. So, you know, can there be suicide prevention programs that are at the local people level? You know, that we don't necessarily have to have psychotherapy, more at the primary prevention. There's some studies, and I'm just going to go to this one. There's some studies out of India and Kenya where they taught just community members, people in the you know, villages or whatever, how to do cognitive behavioral therapy, what it was, you know, how it was, how to recognize depression, et cetera, et cetera. And it worked. It worked in those places where they did that compared to places where they didn't do that education. People were less depressed. People, they didn't look at suicide in the articles that I saw. They looked at sort of screening for depression. But you know, and I saw another one. Just again looking at my students, where they're going with stuff. It's fun. They're going with stuff. It's really pretty exciting as a professor. There are some studies looking at teaching adolescents this idea of cognition, and what does that mean? You know, how do brains work, as I'd like to say, how do brains work, and then them supporting each other, as opposed to, you know, somebody externally coming in, have it at that level. So there's things out there. There's things out there that I think we can do on a community level. And if I could go back to the exercise and diet and some of those things, those can be at the community level, and they're good. You know, when you look at the effectiveness of exercise on anxiety and depression, just using those two, it's as good as medications and psychotherapy. That's what the data show. That's what they show. So, I mean, it doesn't take a lot of exercise, just walking around. Granted, it gets cold in Montana. You know, maybe we have to have some kind of indoor place where we can walk around, but I mean, we can do that locally. I'm actually preparing another talk for Helena College of, you know, what we can do here and now. What can we do to treat depression and anxiety here and now frankly, without needing medications or psychotherapy, you know, frankly, because we're not going to get enough of this probably. You know, I think, and again, I'm probably speaking pretty out of turn here, but because so much of psychopharmacology is done by primary care physicians, do they need more education on some of the intricacies of cycloform? And I think it varies a lot from primary care to primary care. But maybe that's one too, that would bring that to smaller communities if that might have a primary care doctor. So maybe this one, here's one of my quests, if you will. This is one of my quests of my life. For the psych techs, right? Psych techs and group homes, the inpatient facilities, case managers, the level of education for those vary widely. Okay, so it's a high school education, which isn't enough, or a college education, which is probably too much and may not even be directed toward caring for mentally ill people. You know, a degree in psychology may give you very little, quite frankly, and I've had my bachelor's in psychology, so I can say this, doesn't really teach you how to take care of people with schizophrenia. So I think it'd be really useful, and this comes from a community college point of view, that if we had, say, a 1 year, maybe 2 year, very focused program, teaching these folks with direct care how to take care of people with mental illness, and et cetera. So I think that'd be extremely useful. A lot of problems with that. They need to get paid, right? They need to be worth your while. Everybody uses McDonald's as the example, right? Why would you work someplace with, agitated, psychotic people, whatever it might be, when you go to McDonald's, flip burgers for, $6 more an hour, whatever it might be. So we need to do that. And so, if we can have that, maybe that can be something we can put in the communities. Again, am I going out there in places where I don't know? I like to say I'm generating hypotheses. So I kind of keep it back to the science, my science brain here. So yeah, maybe this is something we can do. I mean, it would take some effort, but we could do this. And I'm looking for, they're just sort of random when I threw in there, and I could have a lot of bullet points on this one. I'm just thinking things I can put in here. We talk about peripartum and postpartum depression. Approximately 20% of those people women who have postpartum depression actually have a bipolar disorder. And mistaking those two, and I have another good video on those if you want. Maybe I should have you just get my email and ask me for these videos because they're pretty cool. If you misdiagnose that, it can cause some trouble. If you give someone with bipolar disorder antidepressants without a mood stabilizer, yeah, it can cause some trouble. So another screening thing that we can do. And I think we need to, I call it functional fixedness. And this kind of comes from my being here for 30 years, right? Being in Montana. We've talked about closing higher levels of care that whole time, pretty much that whole time. And I think we have to stop saying that. We need to stop saying that. We need to say, let's fix the lower levels. Let's not even talk about the state hospital. Because it's, there's all kinds of trouble there, right? And there's all kinds of trouble. I know that. But let's fix the lower ones. Let's fix it so people don't have to send, 15 people to the state hospital on a Friday night with COVID. I mean, people going there COVID positive. People going there with, bed sores. So we need to fix the community and just get out, just stop saying close to the state hospital. I really do. So we got 9 people in the chat. Is any of those for me, Desiree?
There were a couple of statements. So Ashley stated that they work less hours. That was, a couple of minutes ago.
Okay.
And Eric strongly agrees with better education for psych techs and aides.
Good. Thank you. Thank you. Come join me. I have a student now from California, and they have a program for that, for this education, direct care education. So yeah, I think that would go a long way in helping the system. Again, now that's a public health thing, right? That's public mental health, because that's a well-trained workforce. So even though it's within mental health, hence public mental health, I think this is, it's just like getting enough people to have vaccinations, to check blood pressure. It's the same sort of idea within the mental health realm. And of course, we need costs through this because that's always going to be when it gets to the legislature, right? How much these things cost. And there's ways we can do that. And I'm sure these are being done. Cost minimization, effectiveness, consequences, and cost benefit analysis. So this all needs to go into the overall process as well. And here's my last. Again, I hope to save some time for questions and just general comments, and it looks like I have. So looks like I'm timing this pretty good. Again, going back to, I really love my essential services, and this most should be inclusion now, I understand. This should be more inclusion to have the different populations, make sure they're all involved in this. And Professor Miller, who presented last week, she turned me on, I'm going to use that term, to how you do this community assessment. And I had kind of share the story of this one when because he had to take this for public health, right? Community assessment, program assessment. And I groaned because it's like, how many things have been part of community assessment? And, you know, we do all this stuff and nothing comes from it. So I groaned until I realized, oh, this is actually very well structured, and I likened it to taking a sodium level, right? Okay, we have to think about it, but it's you know, you design, evaluate. What are we talking about here? You know, are we talking about how do you get services in, you know, very underserved communities? You know, maybe using some of the other lay population. Okay, let's evaluate. What are we looking at? You know, ER visits, suicide rates, medication. What? Let's figure that out and get it. Let's then look at that. Let's actually look at the data, not just how many people did this or that, but how they relate to each other. Start coming up with nice little epidemiological, public health, scientific things for the community, right? The community-based population, participatory research, and then bring her back home, and not just say, oh, this is findings. Let's then use those findings. When we're in Helena, and in other places, I live in Helena, so we have the drug treatment courts. So we're looking into evaluating how it does, the drug treatment court. And so I'm having some students looking into that as part of a public mental health process. So I think this can be done. I think it's big. And this one, University-Based Center for Public Mental Health, yeah, it's probably, I don't know. I debated when we'll put that in there. Do we need another center? I don't know, or just, there's Public Health Center, and U of M, MSU has the Center for Mental Health Research and Recovery. So I don't know if it needs to be something separate, because we have enough stuff anyway, but I really think we can start looking at these issues. At some of the techniques I have, the Montana 13, I call it, with the different divisions. What are we measuring? I think we need to step back and say, wait a minute, let's get this much more structured. It feels to me like a lot of it gets pretty reactionary. Like, we need to have this now. We need to do this now. And it's like, well, wait a minute. They talk about a suicide epidemic. Suicide is not an epidemic. Suicide is endemic. We have a constant rate of suicide slowly climbing. So it's not really a crisis. It's not an epidemic. It's something we've had for a long time. Okay, so how do we take this thing that we've had for a long time and start addressing it? So that's my dream, frankly, is to have something arise. This is part of that dream. I'm literally living the dream here. So that's kind of what I'm thinking. So that's it. That's my presentation. I can go on. I can go on for days. My students can attest to that. And all this has references. Unless I say it's my opinion, I have observed or anything like that. Everything I just said I can find you the reference for it. I didn't list them in here because I thought that'd be sort of extraneous. So let's go ahead, because already there's been some pretty good conversations in the chat room. I'm going to leave this available, but let's go ahead and I'm going to stop sharing and just see if there's some questions or suggestions.
There are. So starting with Ashley, she says regular collaboration and communication within organizations and programs.
Okay.
Jobina stated that one of the systems I didn't hear spoken of is our employment system. If we're working too much and paid too little, therefore needing to work more hours or extra jobs, then we have little to no time for exercise, proper nutrition, or even seeing a provider about our mental health. Without a living wage, we cannot keep or secure housing, which is also a detriment to our mental health. Our employers, are turning their heads on our mental health.
Yep. Yeah. I agree. So
just all of them, or would you like to just?
I actually got them up in the chat now.
Perfect.
So I can probably do it. So, again, when I was making this talk, I guess I had another 5 minutes I could have filled, right? So, housing, yeah, oh my goodness, housing is a problem. That is we think of people who are mentally ill and have substance use problem becoming homeless or unhoused. Maybe it's because they're unhoused, they're having mental illness. So yeah, if you don't have a place, that's Maslow, right? That's Maslow's needs. the lower levels, you need to have food, you need to have housing. And if you don't have that, yeah, a lot of this stuff is not going to have. So yeah, I did leave that one out consciously, again, because I had to leave something out just to fill it. So, but yeah, housing's a tremendous problem. That's definitely one we should address. Maybe I should put that in. I'm gonna get this talk again, so I'll add in housing. That's again, that's not just mental health, that's all health. Housing's a huge problem across the country. Yeah, can you restate them? Yeah, okay. Well, using them locally. So the ones I mentioned is teaching lay people how to do psychotherapy. So what those did, and I can, who is that? It's Bridget. Maybe let me put in my email here. Put that in there. Please feel free to email me. Those are a pretty, that's not going to be an easy thing to do, but I think it can. There's some people working on it in the States. I believe, if I remember, out of the University of Washington, actually. So yeah, I think it'd be really great to have to start doing those in our community. They need to be done again well. You need to sort of look at that in how do you train them well, et cetera, et cetera. There has to be fidelity to the programs and whatnot. But yeah, I think we could do that. Child care is the baseline. Yeah. Yeah. I mean, those, put child care for the next one too. Huh? Now that I know how long this one takes, I can adjust accordingly. So very informative is a broad overview, and that's what I meant it to be. Wish for EBP. What is EBP?
Evidence-based practice.
Evidence-based practices, yes. Yep, absolutely. Yeah, I should have guessed that, huh? Should have guessed that acronym. Speaking on frightening housing system. Yeah, wages, employment. Yeah, I mean, yeah. It's really, yeah, I mean, I purposely just focused on more of the medical side of things. And again, is the more of the health side of things, but housing, employment, education, childcare. Yeah, I mean, these are all integral to a healthy society, frankly, to a healthy community. I don't have good answers for those. I wish I did. Yeah, I mean, that's a large economic issue, right? This is now, very large economics. Maybe I'll get my son involved. He's a businessman. He's in sales. He knows economics quite well. Maybe I'll see if I can get him coming up to talk to his pa. But yeah, I mean, you're exactly right. Yeah, I don't know. I mean, I've been somewhat involved in the housing issue. I mean, there's a lot of issues to be involved in, right? So, but I know the Good Samaritan does a lot of work with housing, the county level. But unhoused is, I think there's like 300 some odd people in Lewis and Clark County that are unhoused, which is, and then other counties have even more, I'm sure. So yeah, I wish I had an answer for that. I do not. Cool. Zero site, another. Yeah, there's quite a few. Yeah, so I might just do one on suicide per se. There's quite a few. There's some local psychotherapies. I think we could probably do some of the. I really do think if we have the interpersonal theory of suicide, and we look at thwarted belongingness and all those perceived burdensomeness, if we translated those kind of technical terms into more of a cultural terms that would bring those to communities, this is what that looks like. Right, and not just suicide, but those earlier ideas. So sort of the preventative ideas, not just, gosh, are you suicidal, but wow, do you feel like you get rejected? Do you feel like you're a burden to others? That might be a place for in clinical settings. Clinical settings, there's definitely the ones I talked about with various pharmacology, various psychotherapies within clinical settings. Those have been shown to decrease suicide, but it's complex, right? I mean, suicide is not one thing. It's I don't know how many different types of cancers are there. There's probably about the same amount of suicides, and it's probably a bit of an exaggeration, but it's a very complex thing, and we've been struggling with it for as long as we've been keeping track, right? We hear that It's a, as long as we've been keeping track, Montana's been high in suicide, as has Alaska and Wyoming. So yeah, those zero suicide is good. And I hope that some of these other ones will work as well. It's a very much of a systems thing. Well, this is great. So final comments. And I have I tried to narrow it down to a few. I don't know if the learning about the antipsychotics was helpful for folks, but I think it's certainly some confusion that I hear. John?
Can you provide a part 2 to this? I mean, can you keep somewhere down the road, pick up and see what we and the outpost communities have done to follow up on some of the suggestions and
Yeah, absolutely. Thank
especially,
you.
yeah, innovations and adaptations.
Yeah. So I guess let's see how would I Desiree, you have a list of people who signed up. And maybe I'm trying to think of how I can operationalize that, John.
Yeah.
Maybe you email me or maybe go through Desiree, or I don't know, we need some kind of way to sort of operationalize that, right? How do I reach out to folks?
Okay.
Yeah, but yeah, I would love that. This is my this is my life work at this point in my life. It's just sort of funny. I mean, my friends are all talking about retirement. I go, I think I might just be starting a new career, like doing this public mental health stuff. So yeah, I would love to do that.
Yeah. Well,
Yeah.
and the next statement, and I'll get off, give others room, is I'm going to sound like a cheerleader, but keep up the great work.
Thank you. Thank you. I thank you very much. That really makes my day. Thank you. Maybe I'll get a hold of the public health people and have Desiree help me with some of these things.
Certainly. And I'll give you the email,
Okay.
the list of who's attended today.
Okay, great. So yeah, I might be emailing everybody, and then if so, please, if I know email can become like weeds. We get a lot of emails, so I'm going to add another weed. Hopefully, it's a pretty weed, like a dandelion or something. Okay. Well, thank you, everybody.
Yep. Thank you very much.
Appreciate this.
We
Thank you.
appreciate this very much, Dr. Munn. This was really
Yeah.
good.
Good. I appreciate that. Thank you.
You're very welcome. All right, everyone. Have a great weekend. Happy
Yeah.
Thanksgiving.
Happy Thanksgiving. Yeah.